Good evening everyone. I am Dr. Hani Diptiman, second year psychiatry resident, and in my last video I was teaching about basics of schizophrenia, and I will be continuing my topic of schizophrenia from here on. So now we will be starting with this topic. See, there was a psychiatrist, Emil Kaplan, who gave the term dementia precox. So what do you mean by term dementia precox? Dementia means cognitive decline and precox means early onset. So this German psychiatrist gave the term dementia precox, and he was the father of modern psychiatric classification. He classified all the psychiatric illness, and he made the earliest classification of the mental disorder. So first there was only psychotic disorders, and based on the codes and the long-term prognosis, he divided the psychiatric illness. And first class was continuous illness and deteriorating codes, which he gave the term dementia precox. And the next thing was episodic illness without deterioration codes. So he classified them as manic depressive psychosis. There was another psychiatrist, Eugene Bleuer, who was a Swiss psychiatrist. He gave the term schizophrenia, and which meant splitting of the psychic functions. So he believed that schizophrenia psychic functions like thought, emotion, and perception are not in synchronization with each other, and they are split. So there are 4 A's of the Eugene Bleuer. This question also comes in NEET PG exam, and in these 4 A's, the first is autistic thinking. So it is a type of a fantasy thinking. So in this, the patient usually is socially withdrawal and is preoccupied with his fantasy thinking. Next is ambivalence. Ambivalence means patient is not able to decide what he wants to do. There is coexistence of the opposite feeling towards the same object. Example, patient will say that I love my mother, but at the same time I also hate her. Next is affect disturbance. So in affect disturbance, there can be inappropriate affect or incongruent affect. So what is mood and affect, you need to know. Mood is sustained and pervasive feeling tone that is experienced internally, and it colors the patient's perception of the world. So affect is outward. It is the emotion which is seen by the clinician, by other people. So if there is incongruent affect, means the affect and mood are not same. So example, a patient is smiling while talking about the death of her mother, while inappropriate affect, it means the emotions are not matching with the setting, like patient is laughing at a funeral. Next is loss of association. So in conclusion, you can just remember, in loss of association, these are just the formal thought disorders. These are the formal thought disorders. There will be no logical connection between the sentences he is saying. Example, patient will say like, I like tea, tea grows in Assam, Assam has rhino. So it is just a type of derailment or tangentiality, any of the formal thought disorder. So these are the 4 A's of the Eugene Bleuer. The next psychiatrist we need to know about is Knut Schneiderian. He gave 4 SFRS, Schneiderian first rank symptoms. Any one of them was enough to make a diagnosis of schizophrenia back then. So there are 3 auditory phenomenon, 3 made phenomenon, and 3 thought phenomenon. So 3 and 2 other symptoms which I will be telling you. In auditory phenomenon, there is echo de la pens or audible thoughts. Patient will think. Patient hears his own thought. Whatever he is thinking, he will hear it in his ears. Next is voices arguing. He will hear 2 or more voices discussing among themselves about the patient. Then there is voices commenting. There it will be like a running commentary. Whatever action patient is doing, he will be able to hear that. Next is thought withdrawal. Patient will feel like his thoughts are taken away from his mind. Thought insertion. Patient will feel that some other external identity is putting some thoughts inside his mind. Then next is thought broadcasting. Patient will feel that whatever he is thinking is being broadcasted to other members, other people around him. There are three made phenomenons. Made phenomenon means patient, first is made feelings or made affect. So it means that patient's emotions will be controlled by external agency. Patient will feel this way, that his emotions are being controlled by the some external person. Made impulses. So impulse, it is the urge to act upon something. So patient will feel like his impulses are being controlled by someone else. Then there is made volition or made act. So patient will believe that his actions are controlled by someone other, third person. Next is somatic passivity. So patient experience a certain bodily sensation and which are imposed by a external force. And there is a delusional perception, means a normal perception is given a false, abnormal and delusional meaning without any logical connection. Example, patient will say that he saw a black cat in the morning, so everyone in this world will die today. So such illogical thing will be called as delusional perception. Now we will see the dimensions of schizophrenia: psychotic symptoms, negative symptoms, disorganized symptoms, depression, anxiety, and agitation and hostility. So first we will see the psychotic symptoms. In psychotic symptoms, strictly includes only delusion and hallucination, while the positive symptoms include psychotic symptoms, catatonic symptoms, and other formal thought disorders. So, hallucination is nearly seen in 5 to 8% of the general population without illness, and the auditory hallucination is most common type of hallucination seen in schizophrenia. It is initially distressing for the patient, but gradually over the time patient develops certain coping strategies with this hallucination. Like patient will distract themselves, they will shout and start singing. Visual hallucination are nearly seen in one third of the patient, but if visual hallucination is there, then definitely 99% of the time patient will be having auditory hallucination also. And visual hallucination is mostly seen in a organic pathology. So this is also one of the reasons that in developing countries like India, visual hallucination is more common compared to other forms of, compared to the western countries data, because in developing countries organic disorders are more common. Now next, tactile hallucination, like formigation. Patient will feel that insects are crawling inside the skin. Patient can also have olfactory or gustatory hallucination, and it will be like patient will smell something burning or altering taste of food, and it will be associated with delusion. Patient can also experience synesthetic hallucination. It involves visceral and deep tissue sensation. Like patient will feel the internal organs are moving and they may be inconsistent with the normal sensory apparatus. Next is delusion. So in easy language, delusion is fixed firm belief that is not culturally shared, and it is seen in 90% of the patients of the schizophrenia, and they are mostly persecutory type. Now we will see the negative symptoms, and they are classified by the matrix: measurement and treatment research to improve the cognition in the schizophrenia. This is the full form of matrix, and they have classified the negative symptoms into group 1 and group 2. So group 1 is has three symptoms: avolition. Avolition means loss of drive to do anything. Anhedonia. Anhedonia means loss of pleasure in previously pleasurable activities, like going out with friends or anything like that. Asociality. Asociality means there is indifference to the social relationship or decreased drive to socialize. In group 2, it will have alogia, which is decreased verbal output or poverty of speech, and blunt affect or flat affect, in which patient will be having near absence of the affective expression. Now we will see the secondary causes of the negative symptoms apart from schizophrenia. Certain antipsychotic that a typical antipsychotic like haloperidol can themselves induce the this negative symptoms. Long term hospital admission can also cause this. Certain positive symptoms can also cause the negative symptoms, like if there is a paranoid delusion, which is a positive symptom, but due to that patient will be scared, so this will make him withdrawn and decrease talkativeness, decreased speech, decreased talkativeness, withdrawn behavior, this will be seen. And depression, there is a syndrome, deficit syndrome, in which two or more primary negative symptoms are lasting for more than 1 year, and it will have a very bad prognosis. Now we will see the disorganization symptoms, and this is the most heritable dimension. Means if father is having schizophrenia and child also has schizophrenia, so the most common symptom they will herit is disorganization symptom, and it includes formal thought disorder, any disorganized behavior. Disorganized behavior is like any socially unacceptable behavior, like patient will urinate in the public, he will start spitting here and there, and catatonic behavior and inappropriate affect. Depression and anxiety is also one of the domains of the schizophrenia symptoms, and depression at times is difficult to differentiate from the negative symptoms of schizophrenia, but mood symptoms can help to differentiate, because at times the schizophrenic patient will say his mood is euthymic, but a depressed patient may say it is sad. There is a Calgary depression scale for schizophrenia that helps to assess the depressed mood, hopelessness, guilt, and early awakening morning depression. While HAMD is used for major depressive disorder. Now, uh, post-psychotic depression, it occurs when the insight again comes back. So there is realization of the illness. So patient realizes that how he was behaving all these days. So in this phase, there is high risk of suicide. Agitation and hostility is also one of the domains of the schizophrenia. Suicide in schizophrenia, nearly 20 to 40% of the schizophrenia patient commit suicide, and nearly 5% of them die by suicide. There are also certain risk factors which further increase the chances of a schizophrenia patient committing suicide, like if schizophrenia occurs early in the age, sorry, if schizophrenia is patient is early in the illness, in the initial part of the illness, and immediately after the admission or after the discharge, frequent relapses are there, and increased psychosis is there, and the insight is gradually improving, so patient will come to know about his deeds, and gradually he will feel bad about it, and his negative symptoms will gradually go away, and during that phase he is at a high risk to commit suicide, and comorbid depression is also one of the major reasons. Now we will see the epidemiology and course of schizophrenia. Lifetime prevalence of schizophrenia is 0.7%. So it means that nearly 7 out of 1000 people will develop schizophrenia in their lifespan. Incidence of schizophrenia, it is nearly 0.15 per 1000 person. It means nearly 15% will develop schizophrenia in 1 lakh population. It is seen that prevalence rates are nearly same all over the world, but the African population who were settled in UK compared to the white UK population, the African population has higher incidence of schizophrenia, and the incidence of schizophrenia is increased in the second generation migrants and also in the sibling of the parents patients.